Well, good morning, and thank you again for having me here. I would say Alex TLC team. I liked it. So you asked me to talk about newborn screening, and I have to apologize. It is like 80% of what I presented last year, but I improved my slides. It's a slow-growing progress. So. But then again, repetition is never a bad thing. These are my disclosures. The newborn screening study was paid for by the Dutch government. So we know that ALD technically it's a simple disease. There's one gene, and and the deficiency in that one gene causes one biochemical problem, the very long chain fatty acids that are elevated. And you can diagnose it already at birth. The biggest challenge in ALD is that after birth we cannot predict the clinical outcome of an individual, not even within families. So even in families, patients can have different clinical outcomes. And they can have the same different clinical outcome, but the age of onset is different. So that is a big challenge. So there are three main syndromes: adrenoleukodystrophy, then the leukodystrophy, and the spinal cord disease. And the spinal cord disease starts in adulthood. And the adrenal insufficiency and the leukodystrophy can start very early on. And this slide summarizes the rationale for newborn screening, but I will take you through the slide. Because, as I said, we have these three core syndromes, and they can start at different age. And it's shown in this plot. Because on the left we see the percentage of patients having this syndrome, and then on the x-axis is the age of onset. And you can see that because that the slope is going like this, that means that patients can start at different ages. But if we just zoom into the first 10 years of life, there's some very important finding, because what does it tell us? That 1 out of 2 boys before the age of 10 will develop adrenal insufficiency. And that is very well treatable with hormone replacement therapy, but it's often diagnosed too late, and sometimes even after children have gone into hospital. What we'll also see is that 1 out of 3 boys will develop cerebral ALD before the age of 10. And it's also very well treatable with a bone marrow transplant, but it's often diagnosed too late. So if patients have neurological symptoms, it's often too late to do the bone marrow transplant. So the very simple thought is that if you would diagnose this condition at birth, you can enroll these children in a follow-up program. You monitor them, and when either adrenal insufficiency starts, or on the MRI little lesions in the brain are seen, you can perform a bone marrow transplant in time. And that was already recognized in 2004 by Professor Jürgen Moser at a newborn screening meeting in the United States, where he said ALD newborn screening saves lives. And everybody agreed, but at that time it was not possible to diagnose the disease at birth. Yeah, you could do it at birth, but not in a high throughput thing, because if you want to do it at birth in all babies, you need a method in which you can run hundreds of samples per day. And the method that was then available took 2 days for a few samples. So the team at Kemp Krieger set out to find a new biomarker, and in 2006 they reported C26 lysophosphatidylcholine, which I will abbreviate as C26 lyso-PC, which is elevated in a newborn heel prick blood, and it's a very strong diagnostic biomarker. In fact, in our lab in Amsterdam, our diagnostic lab, that was also a little bit fed up with the plasma variant chain fatty acids, because it's time-consuming, it's expensive, and so for 2 years we did plasma variant chain fatty acids and C26 lyso-PC in parallel to validate the method. And 5 years ago, the lab completely shifted to C26 lyso-PC for all ALD requests, so not just for newborns, but also for if a patient visits a doctor. That was just a little side note. And then in 2013, New York State was the first place on the planet to start newborn screening. And then, we always have to thank Elisa Seeger for her phenomenal work in that. And in 2016, ALD in the United States was added to the RUSP list, which is a list of conditions that fulfill the criteria for newborn screening. And this is the latest map of the United States. Almost all states are now screening for ALD, but you can see that by the dates that, well, they all started in a different year or a different month, and still some states are not screening at all, even though the condition is on the RUSP list. So outside the US, Taiwan started newborn screening in 2016, and in 2021, regional pilots started in Israel, Italy, and in Japan. I don't know if they are moving towards national screening. I don't think so at the moment, so they're still regional pilots. In 2022, a regional pilot started in the south of Spain, in Andalusia. And I heard from our colleagues in Australia that in Australia the work to get ALD in the newborn screening has all been completed. And I don't know which territory, I think the territories in Australia will start first, but the plan is to start next year. So we're hoping for updates of that. Then back to the Netherlands. In 2013, my colleague Mark Engelen and we heard plans from the Dutch Health Council to expand the newborn screening program, which was running very well, and so there were new conditions that would fulfill the criteria for inclusion. And and I still am surprised that there was this opportunity to nominate ALD. And well, the Health Council, it took 2 years to come to a conclusion, but then again at one day they said, okay, we're going to nominate 40 new conditions to be added to the newborn screening program. And then within a week, the Minister of Health signed the bill. This is a copy of the bill that went to Parliament, where she announced that, okay, the newborn screening program in the Netherlands will be expanded with 14 new conditions, but you cannot add them all at once, because this is a very delicate program. So they were included in a phased manner. You can see that on the right. The first one was embedded thalassemia, and then in 2019 3 conditions were added, and then one in 2020. And still not all of the 14 conditions are included yet. But what's very important in the Netherlands is the so-called the Wilson and Younger criteria for newborn screening, which were already from the World Health Organization set out in 1968. And one of the most important criteria is that early diagnosis must be beneficial for the neonate. So there must be a treatment. And we heard later, afterwards we heard that there was a lot of debate about ALD, because the majority of patients do not, if you include the women, the majority of ALD patients do not develop a condition in childhood. So this is from the report, which says that screening for ALD is only useful in male newborns because symptoms in females usually appear later and cannot be treated. And therefore, the committee recommends to only screen male newborns for ALD in the newborn screening program. And that's interesting because in the United States, in Taiwan, Israel, and Italy, boys and girls are screened. And in Japan and the Netherlands, only boys. And when I first mentioned this in the United States at the Adrenoleukodystrophy Foundation, I said, well, the Netherlands come to screen, but only boys. A lot of people were wondering, why is that? And it took me a while to realize why this difference may be there. And I've listed this on this slide. Because on the one hand, you have the medical ethical perspective, so the Wilson and Younger criteria for newborn screening, and on the other hand, you have the ALD perspective. And if you follow the Wilson and Younger criteria, and we see that there are a lot of arguments to not screen girls, because there's no treatment for the spinal cord, which women develop. So a girl is basically a patient in waiting. There's the burden of knowledge for the child, the right to an open future. It will probably have a negative impact on life. It may have financial consequences, and the loss of the so-called golden years for the parents, knowing that they are informed with an untreatable condition in their child. On the other hand, on the right side of the slide, there's also very strong arguments to also diagnose girls. Because if you diagnose a girl with ALD, you can make a family tree, and often you may identify boys who are at risk for having ALD, who have not been diagnosed yet. So it shortens the time to diagnosis, and parents can make informed decisions, when women at maternal age can make informed decisions. And my skill is in the middle, because even now I am still not decided. I don't think there's a good and wrong here. And nowadays I just say there's only one good thing, is it's screen for ALD. And okay, so the challenge is that the sex-specific newborn screening did not exist and still does not exist anywhere in the world for any disease. So in 2017, when I was asked if I wanted to be the project leader on this project, there was no example available. And that requires a pilot study, because we had to identify, find and develop a method to pick up boys and screen boys for ALD. If we talk about newborn screening in the Netherlands, our huge country is divided in 5 regions, and we have 5 newborn screening labs. And in the pilot, which would last for a year, 2 screening labs were participating, and 4 provinces. The pilot would last for a year, and we know from statistics that in a year, in these 4 provinces, about 70,000 babies would be born. But the task and the challenge that we had was to design and develop and validate a method that would identify males by just using the blood. And as an extra challenge, we were also not allowed to identify untreatable conditions. And if you think about it, of an X-linked disease, you can think of Klinefelter syndrome, Turner syndrome. And if you think about C20-lyso-PC, there are a lot of peroxisomal conditions and also leukodystrophy that you can identify by C20-lyso-PC, and we were not allowed to identify those either. And all we had was a blood spot, a 3.2 millimeter blood spot, and eventually we got 2 blood spots to develop this test. And after a long discussion of how to approach, we decided just to simply count X chromosomes, because males only have 1 X chromosome and women have 2 X chromosomes. And there is this test, it's a validated test, a commercial kit, in which there are that screens for pieces of DNA that are, like here, present on chromosome 3, but it's also present on the X chromosome. And you can well, with genetics, PCR, you can amplify that and you can visualize that, and you see it here. If the blood spot comes from a male or an individual with 1X, you see a 2-to-1 ratio in this test, and in the case of 2 X's, you see a 1-to-1 ratio. This test is being used for screening many other conditions. So the nice thing is that of the company Deviser is that they modified their software, so we could only look at these tests. And actually, there are three of these tests in there. So the only thing we could see was this. We could not screen for trisomy of 21 or other things, because we are not allowed to identify other conditions. And that was very important that they collaborated with us on this. And we integrated this test, this tier, into the existing algorithm that was already operational in New York State. And we place it as a second tier. So in the first tier, the C20-lyso-PC is measured. If it's above the screening, the cutoff, then the X counter will identify individual with 1X. Then again we measure C20-lyso-PC. Takes a little longer, but it's much more specific. And then we sequence the ABCD1 gene. And every time is a negative result, we stop. And if there's no variant in the ABCD1 gene, we also stop. And this should result in just identifying boys with ALD. There were a few other challenges, is that the newborn screening labs do the first tier. The second tier is done by the Department of Human Genetics. And the third and fourth tier are done by a laboratory, genetic metabolic diseases. And we have to finish in 35 days, because after 35 days, parents are notified of the result. Of course, if there's a metabolic disease, they are notified much earlier, but everybody is notified. It's a pilot, so parents were asked to participate and to give informed consent, and also the screeners, because in the Netherlands blood spot are taken often at home. So we had to instruct the screeners, and also if they were a parent with a girl, that they would not say, oh, you have a girl, so you don't need to participate, because we had to test the X counter. And all babies born from January 1st until December 31st could participate in the trial. Well, indeed, 70,000 newborns were born in the 1 year, because in fact there were 72,379. Of these, 1,171 parents did not want to participate in the pilot. So we had a participation rate of almost 99% of boys, and it is very close to the participation rate for newborn screening overall in the Netherlands in that year, which was 99.2%. So this is the results of the first year, where the screening labs measure C20 lysis PC, and before we had set up the cutoff at 0.32. So if the value was 0.32 or higher, we had a screen positive, and those are shown on the right. And we had, throughout the year, we had 507 screen positives that went to the X counter. In the X counter, we had a almost 50-50 ratio of girls and boys, but only if there would be one X chromosome, the C26 lysis PC would be screened again in the third year. And those were 249. Before we started, the lab had access to anonymized random cards from babies to set up the cutoff for the screening, which was set up of 0.15 micromole per liter. And we had some blood spots from ALD babies that we could also test to see the difference between the controls and the ALDs. And on the right side, you see the screening in the pilot, and it's really comparable to what we did 2 years earlier. But only 20 samples were above the cutoff, and those were sequenced in tier 4. And the results are shown on this slide. So we sequenced 20 genes from 20 different boys, and we identified 4 boys with ALD. And these families we refer to the neurologist at the Adrenoleukodystrophy Center. This is the complex scheme of the Dutch newborn screening, and at this stage we are now here in the middle. So if there is a positive screening result, the medical advisor of the RIVM DVP is being notified, and because there is no immediate need in ALD, we decided to make this as family friendly as possible. When there's a positive screening result, first the Adrenoleukodystrophy is notified. So then an appointment is already made for the family. So before the family even knows of the result. Then the general practitioner is informed, because in the Netherlands the general practitioner meets the family and goes to the family. Then the family is notified, and this is never on a Friday. In fact, in the pilot, it was always on a Tuesday. And then already the next day, the family was in Amsterdam. And we asked the families, and they were really happy with that, because it was less than 24 hours from getting this terrible news to meeting with Mark Engelen, who could give them all kinds of information. And also tell them that, okay, this is really a bad thing here, but this there is treatment, so we will help you. So we're now here, this blue thing, which is the end of the newborn screening. So we also set up the long-term follow-up protocol. So when now the family next day meets with Mark, of course, first a blood sample is taken to see if the right baby showed up at the clinic. Of course, that was always the case. And that takes 2 weeks or so to retest. And then the family meets again, often on a Wednesday morning. And then already a blood sample was taken by the pediatric endocrinologist to test for adrenal function. Because since newborn screening has started in the United States, it's clear that now many younger children are being identified that already have adrenal insufficiency. Then the family meets with the clinical geneticist to make the family tree, and then they meet with Mark to talk about, yeah, well, the follow-up. And this continues, and then when the boy is 2 years of age, the first MRI will be taken, and that goes on to every 6 months until the age of 12. But that's beyond the newborn screening. But this functions really, really well. And then, of course, we had to write a report, and that went back to the Ministry of Health. And then last year, on April 17, again, this is a copy of a letter that went to Parliament. The state at that time was the state secretary, decided that it was so good, the pilot, that the Netherlands would include ALD in the newborn screening program, and newborn screening would start last year. And this is a copy from well, a nationwide Dutch paper that talks about ALD being added to the newborn screening program, and it's the first country, so they added that a little bit. And the druppeltje bloed vertelt nu nog meer translates into a tiny drop of blood now gives us more information. So it talks about ALD being added. A little reality check here, because in 2013 we nominated ALD, but it took 10 years to get it to the newborn screening. It could have been earlier, because the pilots actually started in 2019, but we had to stop because there was a problem with the first tier. So in 2020, during COVID, we revalidated tier 1. COVID interfered with everything, but not with the newborn screening. That's one of the only things I know that was not hampered by the COVID. Yeah, so just 2 slides about ALD newborn screening in Europe. So the Netherlands is now screening nationwide. The regional pilots are ongoing in Italy and Spain. We don't know when they will expand to nationwide screening. Several countries are mobilizing efforts, if I heard that's the term that you can use. So often stakeholders like Alex TLC, we try to get the people make decisions to motivate them to start newborn screening. Yeah, but these are all very slow processes, and of course, and then there are still a lot, here they're great, they're white countries for which we don't know what's going on. But it's not just for ALD, also for all the other conditions that are in the newborn screening. There's no consensus in Europe what to screen for. These are, you can see the list of conditions that are added, that are screened for in these countries. And some countries screen for more than 14 conditions, and others screen for between 1 and 5. So that brings me to my conclusions. So male newborns with ALD can be identified by just using dried blood spots. And the algorithm that we validated is consistent with the Health Council recommendations to only screen boys for ALD. I didn't show it, but gestational age, sex, birth weight, and age at blood draw does not affect the C26 lysis PC. The 4 boys that we identified in the pilot are now in the prospective follow-up, and 2 boys are have already developed adrenal insufficiency, so they're already on medication. Last year in October, the nationwide screening started. And I talked about the lack of harmonization in Europe. And then I think one of the important things, if the country wants to, based on ethical considerations, decide to screen boys and girls or only boys, now there are 2 options. So there's no reason anymore not to screen. And this is everybody involved in this big project. And thank you.